In this video, we're going to be focusing on the cardiomyopathies. And it doesn't really matter how you end up with the cardiomyopathy. In most cases, the etiology doesn't matter. In almost all cases, it's irreversible. So it matters instead the response of the myocardium to the insult that gives you the diagnosis. Now, cardiomyopathy, cardio, heart, myo, muscle, pathy, bad. Anything that causes a problem with the myocardium can cause a cardiomyopathy. So it could be hypertension, an arrhythmia that's long-standing, ischemia, infiltrative disease, viruses. It really doesn't matter what the etiology is. What matters instead is the body's response. There are four we're going to talk about. Let's start off with dilated cardiomyopathy. This is a two-chamber heart, left atrium, mitral valve, and then the thick-walled ventricle with the aortic outlet. In dilated cardiomyopathy, as the name implies, the chambers dilate. And they essentially become thin-walled and floppy. Now you remember from step one that actin and myosin generate contractility force. If you have good overlap, there's maximum contractility. If they're too close together, there's nowhere for them to go. In dilated cardiomyopathy, they spread so far apart that there's very little actin and myosin overlap, so there can't be any contractility. That's essentially the problem with dilated cardiomyopathy. You have decreased contractility. Now, I said etiology doesn't matter, but when you talk about dilated cardiomyopathy, you want to think of viruses, wet beriberi, alcohol, and ischemia. And as you'll learn, some chemotherapeutic drugs can do it too. The patient is going to present with a systolic CHF. And so they'll present with symptoms typical of CHF. Orthopnea, paroxysmal nocturnal dyspnea, and dyspnea on exertion, caused by pulmonary edema, the crackles, and the peripheral edema. Now, if you see systolic CHF, of course, you're going to get an echocardiogram, and all of these structural lesions are going to be diagnosed by echo, and you'll see the dilated chambers. The treatment is going to be primarily focused at the CHF symptoms. And as we learned in the CHF lecture, that means everyone gets a beta blocker and an ACE inhibitor, and you're going to control the symptoms of fluid with diuretics, particularly the loops like furosemide. Now, all of these lesions, all of these cardiomyopathies can be treated with transplant definitively. And then every once in a while, you'll get an etiology specific like alcohol, where you can stop the alcohol and hope that it improves, or stop the chemotherapy and maybe it'll get better. But for the most part, it's going to be beta blocker, ACE inhibitors, and diuretics, then get the transplant if it's bad enough. The next two have similar sounding names. And what used to be hypertrophic obstructive cardiomyopathy is now just hypertrophic cardiomyopathy. That's what we're going to talk about next. We'll compare that to the concentric hypertrophy. Hypertrophic obstructive cardiomyopathy. Let's first draw the picture of what it looks like. This is a normal ventricle with an aortic opening. In hypertrophic obstructive cardiomyopathy, what you're going to get is an asymmetric septal wall thickening that causes a left ventricular outlet obstruction. It covers the aortic opening. This is almost always caused by genetics, and it's a problem with sarcomeres. The patient is very unique. Now, this is essentially aortic stenosis, right? There is something in the way of the aortic opening. So the patient is going to present with a murmur that sounds like aortic stenosis. But old guys with coronary artery disease get aortic stenosis. This is going to present in the young athlete, which makes it very identifiable for board vignette. Young athletes who are going to present with dyspnea on exertion, syncope, or sudden cardiac death. Now, if the patient presented with sudden cardiac death, they're already dead, they're not your patient. But a family history of early sudden cardiac death or an athlete with dismounting exertion, syncope, and a murmur kicks off the potential for hypertrophic obstructive cardiomyopathy. Because this is a structural lesion of the heart, you're going to diagnose it with an echo. And the echo is going to show you an asymmetric hypertrophy. Treatment, definitively transplant. But you're not just going to walk around transplanting everybody. So what do you do for people with medical management? Well, the problem is that you've got this asymmetric hypertrophy with an aortic outlet here. And if the ventricle's volume decreases, it essentially totally obstructs the outlet. So the goal will be to keep the ventricle filled. You do that by one of two ways. Keep the ventricle filled by avoiding dehydration, increasing the preload. And avoiding dehydration doesn't mean drink a lot of fluid. It doesn't mean avoid diuretics. It means don't get your heart rate up. Maintain the intravascular volume of the ventricle. So these kids are not allowed to exercise. They're not allowed to do sports. They have to stop. And the way that you can improve ventricular filling is by increasing diastole. You increase diastole by decreasing the heart rate, which means beta blockers and calcium channel blockers. And the calcium channel blockers we're talking about are verapamil and diltiazem. This is essentially a diastolic failure, in that if you don't maintain diastolic filling pressures, there's left ventricular outlet obstruction and they die. So you treat it the same way. You avoid dehydration and control their rate. But there's a thing there, right? So if you just remove the thing, and then there's no more outlet obstruction. So to remove the thing, you can either do an alcohol ablation. This is useful in patients which are poor surgical candidates. Or you can do a myectomy. Simply remove the muscle that's in the way. Every once in a while, they're going to need an AICD, a defibrillator. And these are for people who are at increased risk of death. Generally, the people who are at increased risk of death have ventricular arrhythmias documented, or they've already died and been resuscitated. Most patients don't need an AICD, but the people who are doing really poorly or at increased risk of death do. And finally, for HOCM, first-degree relatives should be screened with an echocardiogram. Lots to know about HOCM. If we compare that to concentric hypertrophy, something you're going to see all the time, HOCM is actually pretty rare, but you're going to get a lot of board questions about it. Hypertrophic cardiomyopathy, that is concentric hypertrophy, is actually quite common. This is yet another cross-section of the heart. This is the muscle, and this is the muscle itself. This is the ventricular space. Much like you going to the gym and working out, your muscles will hypertrophy. Well, if the heart is forced to push against an increased load, say from long-standing hypertension, it's going to get big and beefy. So what happens is the muscle gets big and beefy. It has no problem squeezing against that increased resistance. The problem is that there's literally not enough room to relax. So the pathology is almost always hypertension, and a long-standing high hypertension. But the patient has no problem pushing things forward. In fact, the contractility is probably increased. The problem is, though, that it can't relax, so the patient presents with a diastolic heart failure. Because you see the heart failure, you're going to say, okay, I'm going to get an echocardiogram. The structural heart disease, so you're going to see it. But what you'll see here is a concentric hypertrophy. It's equal all the way around, whereas HOCM was asymmetric. Concentric hypertrophy is concentric. And the thing is here, it's just diastolic CHF. And you'll recognize that the treatment for diastolic CHF is very similar to the treatment for HOCM. You avoid dehydration and rate control. Beta blockers equal to calcium channel blockers. Now, there's no alcohol ablation and no AICD And maybe a transplant will work because it is a structural heart disease. But the main goal is to control the hypertension. It's probably irreversible, but if you just simply control the blood pressure, they won't go into heart failure symptoms. And hopefully you've caught it early enough where it isn't so severe. Lastly is going to be restrictive cardiomyopathy. Similar cross-section as our concentric hypertrophy. What happens in restrictive cardiomyopathy is that some stuff gets in the way of the ventricle, literally fills up the ventricle wall with something other than myocytes. So rather than muscle, there's just gunk. And what that looks like is all this gunk. And just like in concentric hypertrophy, there's no room to relax. So the patient is again going to present with a diastolic dysfunction. Here the pathology actually matters. So the stuff, what's the junk, what's the infiltrative disease that can do it? The three big ones are going to be amyloid, sarcoid, and hemochromatosis. Now there are some cancers and some idiopathic fibrosis that can do that, but don't really look for these. Look for amyloid, sarcoid, and hemochromatosis. The patient is going to present with a diastolic CHF, and because you saw the CHF, you diagnose it on an echo because it is a structural heart disease, and you will see the restrictive pattern. And the echocardiogram might also give you some idea of the underlying etiology, because if you see a speckled pattern, it's amyloid, and if you see patchy all over the place, it's sarcoid. But that doesn't really help you. What helps you instead is the other things in the vignette that tell you, hey, there's probably an etiology you need to look for. If you're going to have amyloid, look for a peripheral neuropathy. If they're thinking sarcoid, they're going to give you pulmonary disease. And if they want you to go the hemochromatosis route, they're going to give you cirrhosis or bronze diabetes. More about that in the GI lecture. Sarcoid is talked about in the pulmonary lectures. So if you get this echocardiogram and you see a restrictive pattern, you have to go for amyloid, sarcoid, and hemochromatosis. And of course, I've identified those in the vignette. If amyloid, you want to do a fat pad biopsy. A biopsy of the gingiva also works. For sarcoid, you want to get a cardiac MRI and then do an endomyocardial biopsy. And for hemochromatosis, screen with a ferritin, which will be elevated, and then get the genetic test. But regardless of the etiology, what are you going to do for restrictive cardiomyopathy? Well, it's a diastolic CHF. So, rate control, beta blockers equal calcium channel blockers. And here, in the actual presentation of restrictive cardiomyopathy, you're going to get overload. And so you'll want to do gentle diuresis. You diurese them sufficiently so that you don't have the symptoms of volume overload. They don't have the hypoxemia and the crackles. But you have to be careful with how much diuresis you do, because it is a diastolic heart failure. If you drop the preload too much, there won't be anything to fill the ventricle. So it's gentle diuresis, beta block equals calcium channel blocker, and of course, transplant is definitive. But if you can, what you want to do is treat the underlying disease. Although unfortunately, this usually doesn't work, and the mortality is very high. All right, so let's step back and take a look. 4 diseases we talked about. Dilated cardiomyopathy, anything can cause it. It's systolic heart failure from low EF. Diagnosed with an echo, beta blocker or diuretics. HOCM, genetic, young athlete, syncope with a murmur. Get an echo and show an asymmetric hypertrophy of the septum. Rate control, avoid dehydration, and some other stuff you can do. Concentric hypertrophy is caused by hypertension. It is a common diastolic CHF. Avoid dehydration. Beta blocker equals calcium channel blocker. Control the hypertension. Restrictive cardiomyopathy something gets in the way of the ventricle, literally infiltrates it, amyloid, sarcoid, hemochromatosis. Echo to diagnose it, then learn a little bit about each disease. Beta blocker equals calcium channel blocker for rate control because it is a diastolic CHF, and then gentle diuresis when they come in with volume overload. The goal being treat the underlying disease. That's cardiomyopathy.